We're gonna find. He seems like we're saying it's gonna happen.
Maybe nice guy.
Come on
I
now.
know us.
Now I remember.
I was say, I can't get it back over. Close, that was it.
The mandate report.
Yeah, like.
I'll come and get some aspirin, I'll be right there.
Ask a lot of questions. and over
That's right.
time, it's a little, you know,
All right.
less.
You found your place in this world. Well, at least at this table. Oh, man, I don't know what to do being on this side this today.
No,
It's like seeing a different room.
that's right. Different perspective. Well, that's what. They have to reset it.
Never did it again, and I thought that was terrible.
Yeah.
Yeah.
I get the.
Yeah, yeah.
And no,
Yeah.
I can't read that. Little symbols.
I got to do last time, they put the power button here instead of there, and I just did it, I was like, I'm not gonna call IT for this, I'm gonna free.
I can't get in the middle.
I got it.
Yeah.
Oh, did you drop something?
No.
Try to get this together, okay. All right, I'm back in
We'll have to
action
stand
now.
if we're gonna have a fun.
That's good. Right. It's just.
Go. All right.
All right.
It only gets to
Good look at.
no problem.
Just go.
I don't know.
I promise not to laugh.
Laughing already. I know that.
Ones that I like,
Need a flaky attendees.
like that, I need to do a lot of notes on, I'll.
The other side.
Yeah.
Yeah, yeah, disappear.
Wait, let me see.
It was up here, but once you,
I wonder if mine, because the other one.
so it shows like this.
Oh, she did it over.
Okay, so you would just, and it automatically. With everyone. I thought you would have to every download and all that. I know, it's so late. Right.
I was hoping nobody would
Highlighter. I like the highlighter.
Rub it in.
There we go. This is the pad. I wanted to change the color. The highlighter is this one.
See, your mine's close to me.
Hey, Maxine.
Again. There you go.
That's great, I've got a long time.
Oh, yeah, I like them now.
I like it. It just works.
Yep. Hey, there was only like 4 things on. Yeah, agenda. Okay. Yeah. This is from Schitt's Creek. Oh.
All right. Welcome, everyone. Welcome to the March 21, 2024 Maryland Healthcare Commission meeting. Usual introduction. This meeting is a hybrid commission meeting. There are several of us, a good number of us here in room 100 and additional commissioners participating by Zoom. The rules for our hybrid meeting continue to apply. I will begin with a roll call of commissioners. During the meeting, I'll ask that commissioners and presenters identify themselves before speaking to allow commissioners and the public to know who's talking and have the same knowledge of those of us here in room 100. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask that commissioners and presenters mute their electronic devices when they're not speaking. I'd also like to ask commissioners attending remotely to avoid putting substantive comment in the chat, as it can be difficult for those of us in the room to see the comments. MACC posts documents that will be acted on or discussed at least a day in advance, so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the commission's website and on our various social media channels. So, I'll call the roll. Commissioner Bandari, welcome. I see you on the screen. Commissioner Blake,
Here, present.
welcome. Commissioner Boyle,
Here.
welcome. Commissioner Bazinski, welcome. Commissioner Cheatham,
Here.
Welcome, Commissioner Douglas.
Here.
Welcome. Commissioner Gilroyd.
Here.
Welcome, Commissioner Gilmore.
Here.
Welcome. Commissioner Jensen, I see you there. Here. Welcome, Commissioner Ojukutu.
Here.
Okay. I always do this to somebody one time each meeting, sorry about that. Commissioner Spinner. Commissioner Spinner. Hey, Commissioner Stratton-Duncan, welcome. Commissioner Wang,
Here.
welcome, and Commissioner Wood. All right, we have a quorum. Before we begin today, I would like to recognize Linda Cole, Chief of the Long-Term Planning at MHCC since it was established in 2000.
Trust me. What the plates are gonna be, the food's plenty.
Somebody probably wants to go on
The
mute.
plates are a little thin.
Well, get thick ones. Anyway, Linda's been, she's been the chief of long-term planning in MHCC since it was established in 2000, which is an
What's up?
excellent example of long-term planning. Prior to
Oh,
MHCC,
sorry.
Linda was a health planner at the Health Resources Planning Commission. Those two jobs add up to many years of service to the state of Maryland. Linda is an
Where's
expert
it
in
at?
long-term care planning, particularly for nursing home and hospice services, and has worked collaboratively with those providers to establish data collection programs and new standards for care. Linda has been a staunch advocate
that's
for
what these were
incorporating
supposed to be all
quality
red.
standards and the CMS 5-star rating results in the certificate of need review processes. I want to thank Linda for her many years of service at MHCC, and it has always been a pleasure to work with you during the time I've been on the commission. And wish you the best for the next chapter of your life.
Yes.
Turning to agenda item number 1, items A and B. This is the consent agenda. We have 2 items on our consent agenda. Approval of the commission minutes from February and a project change for Hygeia Detox at Camp Mead LLC. This is a project change recommended by the executive director that does not involve a change in the financing mechanism and is permitted to be part of the consent agenda under Code Mar 10240110. Does any commissioner wish to discuss, remove an item from the consent agenda for discussion? Hearing none, is there any objection to adopting the items on the consent agenda? Hearing no objection, the consent agenda is adopted. Agenda item number 2 is an update of activities. Commissioners, you've received written updates from your centers. Do you have any questions on the written updates? I had a question on where are the costs? Do we know why it jumped up to 2,000 users from about 400 users?
Yes, that was as a result of the release of the new episodes at the end of December. And that included, I think, a total of 24 episodes for the commercial market and 17 episodes for the Medicaid market. So I think that generated considerable more interest, certainly among the providers. We don't know what the mix of providers and consumers has been, but that's the driver behind it.
That's good. It would be great if we could keep the number up. And I had another question, but if anybody else has one, you jump in. I was going to ask about the CHIT ad hoc data request, which is about the urgent care centers. I was just wondering if we were going to get a report here on urgent care centers.
Is that David or Teresa? On urgent care.
On the, it's under Shankar. It's the CHIT ad hoc data request on the distribution and analysis for urgent care centers. And I was just wondering if the commission was going to get a report on the results of that as well.
Sure. So Shankar, you have to come up. We can't hear you.
So that request actually was made by Nick from David's area. They wanted to do a market scan to understand what is the distribution of all the different urgent cares in state of Maryland. And our analysis was just to give kind of a descriptive analysis showing where the different centers are available and some additional information that will help them to locate the physical address of those centers. So that is the only minimum scope. Anything beyond how that is going to be used and what is the larger scope, I would ask David or somebody from David's team to explain that.
So, good afternoon, Commissioners.
Sure.
So we compile data about every 12 to 18 months on the utilization of health IT and how that's affecting care delivery in urgent care centers. And the data that Commissioner Sargent, Chairman, was talking about will feed into an information brief that we're aiming to get out in April.
Okay, so that will come back to us, because
Yeah.
mostly what triggered my question is reading it. We just haven't seen much of that at the commission level about urgent care centers. There probably are a number of commissioners that will be interested in
That's true.
seeing a set of that data sort of appropriately targeted to look at.
Very good.
Ben, do you have any supplements to the updates?
Yeah, I too wanted to recognize Linda. I was trying to think of the three key words. They tell you, talking about three key points. And, you know, over the years, she's been capable, extremely organized, and I think most importantly, trusted by the industry. That any meeting we had on long-term care, if Linda wasn't there, there was a question of why she wasn't, and since she knew the industry so well, I think people did not want to proceed without having her input present in the room. She's going to be tremendously missed by commission and particularly staff over the time. I've been executive director. I've always been able to count on Linda to deliver whatever it is I've asked her to achieve or produce. And I think as we leave, I think of my 3 or 4 key accomplishments over the last several years are the work that took nearly 2 years in modernizing our long-term care regulations. That was done just at the just before the pandemic started. The pandemic had some impact on how we thought the incorporation of quality measures was going to be rolled in. But I think we put a good process in place for moving forward and looking more carefully at the ongoing performance of the nursing home community. She's also been the long-standing stalwart representative with the hospice industry. Those of us who have used hospice know how important hospice services are, but there are some challenges in Maryland working with the industry. The long-standing perception is that the industry is assigned based on county, and although we have no doubt that they all do good work, our efforts to add more competition in the market for these services has sometimes been not fully appreciated by the industry. Linda's been very patient with them, worked with the industry as well as the legislature to understand the importance of not only high quality, but competition as we move forward. That is a work that is still going to continue in Linda's absence, but I think she's built a strong relationship of trust with the industry that does important work, but yet is very aware of the competition in the industry. And lastly, and most recently, Linda led a group that looked at how we could expand palliative care services. We're not finished with that work, but the work that she established with collaborators here in Maryland, as well as with the National Association of State Health Policy, consortium of state organizations that work on healthcare reform, is going to be important groundwork as we move forward into the next model, the next innovation model with the federal government, which I'll turn to next. But First of all, want to, along with the staff, wish you all the best. Please stop by periodically. We know where you live and it's only a short walk away almost. So congratulations on your many years of service. We'll look forward to seeing you even after your retirement. Next, I wanted to, yes.
Question, you're gonna be missed, to put it mildly. What are we doing to replace this kind of expertise? Not that you can never be replaced.
So-
Stop aging.
So we have,
Based on the last meeting.
we have already started the recruitment process, and a number of very capable, internal and external candidates have applied. That interview process will start in the upcoming month. And we look forward to, we probably won't have any announcement at the April meeting, but certainly, I think we would have a conclusion, in May. The next item, that I want to just be sure everyone is aware of, and I sent this out, shortly before this meeting, is the AHEAD model, proposal, from Maryland was submitted to the Centers for Medicare and Medicaid Innovation on March 15th. I want to note it was due on the 18th that we were showing our enthusiasm. We got it in 3 days in advance. That model is going to be, I think the hope is that it will carry forward the Maryland total cost of care model into the next decade. CMS has indicated that up to 8 states in total will be eligible for this award. The award will be announced, we think, in mid-May. That's what they've told us so far, with a 18-month preparatory period, with the model itself launching in January of 2026. So there's going to be a lot of work that's needs to be done to lay a framework for this new AHEAD innovation if we're fortunate to be successful. If we are successful, that would mean that the total cost of care model would end a year early, which I think that would be fine. That we would be folding into a new innovation model. If we weren't successful, the total cost of care model would continue, and then we would be negotiating with the federal government, beginning probably in mid-2025 to late 2025 for extended total cost of care. But the hope is that we are folded into the AHEAD initiative, because AHEAD will incorporate all of the requirements and innovations under total cost of care, and then some, particularly with a greater focus on fully integrating Medicaid MCOs into the total cost of care model, principally through a variety of innovations focusing on primary care and behavioral health. The role of the Healthcare Commission was talked about in the proposal, although not as fully as we would like necessarily, but it did talk about our role in primary care and our role in developing the APCD database, also called the medical care database. That will be used for benchmarking performance as we move through the AHEAD model, as we are using it today. But I think it does indicate that there'll be additional importance and reliance on that data system, as well as, I think, some support for filling in on some of the gaps that we've talked about in the past, particularly the lack of information on ERISA protected commercial privately insured employers who do not submit to the current all payer claim database, medical care database. Today, because of the Supreme Court decision in 2015 that confirmed that self-insured employers do not have to submit information to state APCDs. Somewhat of a disappointment, and the federal government has committed to work with states to enable that data sharing, but to date, there's been no progress, on that.
Is there anything going on? Because it's been like, we're on our third presidential administration.
Yes, it's third, that it came out late in the Obama administration. And then, late in the Trump administration, the 2020, Transparency Bill, No Surprises Act, did provide for funding for states to work with the Department of Labor to affect a data collection. But the Biden administration hasn't really moved forward with that requirement under the No Surprises Act, unlike a lot of the other provisions. So stay tuned
For
on that.
the newer commissioners, it's actually an important issue because it takes about half of the data out of all calculated.
Out of the commercial. And one of the ideas that we have discussed with HSCRC is that as we move the medical care database to being a population-based database in the absence of the ERISA data, that we would work with them to develop a scheme that would allow us to weight up the commercial market to represent its real share of the Maryland insured market with Medicare and Medicaid. The fact is that we get all the data from Medicaid and most of the data from the Medicare, either through traditional Medicare shared with us directly from CMS or through Medicare Advantage plans that submit directly to the state. But we have this gap in the commercial market that if we're going to do representative population-based database, and for example, simple question like how many people in Maryland have diabetes, from the people who sat on the call, the seminar earlier, you can determine that at the practice level, but at the county level or at the state level, an MCDB would be the appropriate vehicle to find that, determine that. But because we have this gap in the commercial market, it's kind of hard to extrapolate from what we have to what is reality in place around the state. So the best situation would be for the federal government to work with states to allow this data to come through. But I think there are some workarounds that we'll have to consider. Any questions on that?
It's a question on the primary care investment is to bring in the Medicaid MCOs and such. I thought I saw in the proposal there was a focus on the FQHCs. Is that in fact true, or will there be investment across all primary care providers?
It's my understanding that it's going to be all primary care providers. I mean, historically on some of the CMMI initiatives, FQHCs, because they are paid differently than a practice. If, for example, Dr. Kuczynski's practice, they are paid more, that folding them in and making them eligible has been a tug of war because they were already reimbursed at a somewhat higher rate. And the thinking was you want to have an initiative that doesn't double pay, but appropriately pays all providers equitably. So historically, FQHCs have sometimes been carved out. I think the thinking here in Maryland is we want to figure out a fair, equitable way to carve them in. But the Medicaid initiatives would be focused on all primary care providers.
Thanks.
To that end, I think that although not discussed directly in the model, some of the initiatives related to long-term care and palliative care are going to be present opportunities for the commission to propose those. Health Secretary will be leading this initiative. I think that the palliative care community did already have some discussions with the Secretary, and while she was enthusiastic in palliative care, message was, if we are awarded the HEAD model, that's the appropriate time to consider. Lastly, on one note of I think public attention is in late February, Change Healthcare announced a significant data breach. If those of you who are actually submitting providers, submitting claims, has real impacts on operations. It does affect the Healthcare Commission in two ways. One, Change Healthcare is a certified claims clearinghouse, and it's also a registered health information exchange in the state. Under our regulations for clearinghouses, Change will have to report to us on their findings on the breach. Of course, they're still doing forensic examinations and investigations currently, but we expect that they would submit that report in the coming months as this investigation is completed. It's noteworthy that many providers are still impacted, and payers have taken various steps to backfill reimbursement that has not been flowed through normal channels over the next couple weeks. Change Healthcare has suggested they hope that all of this is resolved. Secondly, as mentioned earlier, Change Healthcare, one of the entities that they had acquired over the last several years, was the episode grouper that MHCC presents on Where the Cost. We mentioned that earlier, that Change had actually helped us develop the 24 episodes for the commercial market and the 17 for Medicaid. They did share data with us, but we do not have an ongoing data linkage. The last data transmission through a secure FTP channel occurred in mid-December, well before the identified breach, and no linkage currently exists. Kenny Yates Trotman is monitoring their progress on connecting, and Ken's group would oversee the contract that we would have with Change Healthcare for continuation of the episode build going forward. The challenge for us is there's really this particular grouper has been purchased by several different entities over the last 5 years. Change is the last entity to purchase it, and it would be somewhat very disruptive if we had to identify another episode model that would not be consistent with what was ever developed back in 2017 when we got started. So we're hopeful that this all can be resolved, but we're being particularly cautious given the data breach that Change that is had a significant impact and demonstrates, I think, at the time of the Change was acquired by Optum United Healthcare. The initial acquisition was announced in 2022. It was approved, but or challenged by the Department of Justice, and FTC was rejected in federal district court. I believe it was in mid-2023. One of the concerns that some of the folks that raised antitrust concerns was the consolidation of the vertical integration of healthcare organizations that would be affirmed by the acquisition of Change by Optum United Healthcare. I think in some ways this has come to fruition that, yes, of course, large healthcare systems have robust security, supposedly, but they also represent very compelling targets for threat actors in the cybersecurity space. And as you consolidate information, ultimately, what single organizations, even though, of course, there are multiple enterprises and servers that are used, you present yourself with an additional target. Whether we would investigate, kind of not as an investigation, but as a policy concern for the legislature, or we would be directed to do something like that, I think is yet in the air. But I think it's appropriate. Historically, there's been lots of discussion about market concentration on the part of insurers or market concentration on the part of healthcare providers. But the vertical integration that's occurring in healthcare today is, I think, a big concern as well. And we really don't have a good handle on how that is and what the implications are. So I'll stop there. Is there any other questions?
I have a question on the Change one. Is the MHCC, is there anything that we're doing to prepare for because Change is not able to transmit claims from physicians and hospitals to carriers to get paid, there's gonna be a delay. And then there's gonna be a huge, like, catch up at some point, right? As all those claims go barreling through the system. Are we prepared in terms of the managing the database to have like the drop off and what we get reported, then it's gonna all come.
Well, that's a good, I mean, in terms of the data flow, that's a good point to the AP, into the medical care database. There's gonna likely be a gap because although carriers support, submit on the basis of when services were delivered, when claims were paid determines when they actually are
Right.
reflected. In the
Because they don't have a
days
claim,
delay.
they can't submit it yet.
We have not really thought about that. It's a good suggestion. We'll definitely look into that in terms of, our MCDB. One of the criticisms of it is that it's not as timely as people would like. And, in the pandemic period where we needed to know how many infections there were yesterday. And we would say, well, we could tell you 6 months ago. That didn't really help very much. And we have accelerated that whole acquisition process, but payers, we get the data after claims have been adjudicated. So there's only a certain amount of time we can gain. It's never going to be the real-time data system that is needed for public health surveillance, generally that is now recognized as needed. And when the pandemic started, was sorely absent across the United States. I mean, a lot of things that have been done by CRISP were done because no one else could do it. At the start of the pandemic, there was no real-time information on infections, infection spread. The best thing we could do was something like we said, well, we have 6 months data, but that's not going to help. So we recognize that the APCD will never be, the real-time public health tool that is recognized as needed, but it does provide, broad utilization information and performance information on the industry generally.
Any other questions for Ben? With that, I think Mr. Troutman, you have a new staff person to introduce.
Yeah.
That would be good.
We'll have to defer that.
He's doing her work.
So maybe we just move on back.
We want to come back after the next agenda item. Is that- We'll turn to agenda item number 3. Mandated health insurances evaluation. So insurance article 15-1502 annotated code of Maryland requires that every 4 years, the commission must evaluate existing mandated health insurance services and make recommendations to the General Assembly regarding decision-making criteria for reducing the number of mandates or the extent of coverage. The General Assembly may consider these findings to determine whether to enact proposed mandates and whether to repeal existing mandates. Tracy Hughes, the Vice President and Principal Consulting Actuary with Lewis and Ellis, will present the findings of this study or MHCC staff seek the commissioners to approve the report. Tracy, you have the floor.
Thank you. Hi, good afternoon, and thanks for your time today. If we want to go ahead and jump into the next slide, a little bit of background on the analysis here. We were engaged by the commission to perform a comprehensive comparative review and actuarial analysis of the state mandated health insurance benefits and services, both in Maryland and its surrounding states. This is required every 4 years, as was mentioned before, via 15-1502 of the annotated Maryland Code insurance article. On that same location, the mandates are located in Title 15, Subtitle 8. There are 68 mandates in total. We've listed some of the major resources we use for this analysis, including insurance carrier surveys that we conducted with some of the major insurance carriers in Maryland. Next slide. So the first step we took in this analysis was to determine the applicability of each mandate to the health insurance markets, those being individual, small group, and large group. In this context, large group extends its applicability to the state employee health plan. Even though there is a large portion of this plan that is self-insured, it falls under the category of a public and non-ERISA plan, and thus it is subject to state mandate regulations. There's a full table outlining the applicability of each mandate in the report. To summarize it, 56 out of the 68 total mandates apply to all markets, therefore most apply across the board. Since the prior comprehensive mandate analysis, which was published in 2020, but much of the analysis was done in 2019, 7 mandates have been added and 7 mandates have been amended and 9 mandates have been added. Next slide, please. The next step was to compare the mandates to the essential health benefits. These are a part of the requirements from the Affordable Care Act. All individual and small group insurance plans must cover 10 essential health benefits. This is further defined as a health plan that provides benefits that are substantially equal to a state's benchmark plan. The benchmark plan for individual and small group markets in Maryland is listed there. It's a small group plan from Care First under the Blue Choice Network from 2017. And again, there's a detailed table acknowledging each of the mandates and its applicability in the benchmark plan. To summarize, 57 out of the 68 mandates are covered by the benchmark plan, so the majority are covered. Next slide, please. And then we went into a full cost analysis of each mandate presented as a percent of premium and as a percent of the state's average annual wage. This was done for each market, and we also separated out the state employee health benefit plan. On the left, there's a table that shows the 2022 premiums per member per month. You can see part of the reason the state plan is parsed out is because the premium is much larger. And since there is so much self-funding that goes on there, these aren't truly pure premiums. They're more like funding contribution estimates. And then the table on the right in this slide shows the total full cost as a percent of premium and per member per month amount, dollar amount. If we want to, so I'll address this here and then on the next slide as well, but you can notice that the percent of premium for the individual market is a bit larger, even though the dollar amount isn't quite the difference between the other markets. And so if we move to the next slide, we attributed a couple of items driving this difference in the individual market impact as percent of premium. And the largest of those being the 1332 waiver reinsurance program, which decreased the premium per member per month collected by the carriers in the individual market. So if you noticed from the previous slide, the individual market premium was the lowest premium PMPM of all the markets. And that is in large part due to the reinsurance program. So that, that resulting in a somewhat comparable dollar amount PMPM still being a larger percent of premium in the individual market. There's also the presence of anti-selection in the individual market, less so because of the open enrollment period, but it still is present that individuals will elect to enroll in the individual market because they expect to utilize services in an above average manner. So that also puts some upwards pressure on utilization and cost, or higher utilization to overall cost.
Tracy, I see a number of puzzled faces here in the room on the individual market. And so because of the reinsurance program in individual market, and Tracy, correct me if I'm wrong, the reinsurance program basically covers a portion of what would otherwise be paid by premiums. So what is the denominator for the individual market is only a portion of what the total unreinsured premium would be. And actually, I think if you added up everything that was paid for in the individual market, it would end up being more than 100%. Am I saying that right?
Yes,
Yes, it's because some of that,
Some of it is subsidized through the reinsurance program.
right, and some of the subsidies to the reinsurance program are fees from the small group market. Subsidized.
No.
Nice.
If you're in the individual market, the true cost of the insurance product is not what you end up paying, even if you don't receive any other individual cost sharing or premium assistance. That reinsurance makes it more affordable, which was the aim of the program to begin with.
yes, that's correct. Any other questions on that before we move on? I know that's a little bit of a
Jesse, can you go-
concept.
Jesse,
Go
can
ahead,
you
Dr.
one slide
Bernard.
back, please?
Excuse me?
One slide back, previous slide.
Mhm.
So grand total, how 596 came, and on the grand total other side 101. How did we come to this number?
Oh, like you mean, how do we get the grand total out of each of the markets separately?
Yeah, the last one says grand total. How we came to 596? Is it average of all the number on the top or something? How did this number come?
Yes, this is a weighted average by premium, if I remember correctly, though. I might check myself, pull up my model here, but yes, it is a weighted average of the all individual, small group, large group, and state plan.
I feel like I tried to do that one for that, so.
Thank you.
Was there another question?
I was just wondering if you tried to quantify the anti-selection, the costs in the individual market associated with people waiting until they're sick. That's my layman's definition of what anti-selection is.
Appreciate that.
Yeah.
Appreciate that. Long term.
Was that any part of your thing? If it's not, that's fine. I just thought I'd ask.
No, as far as trying to quantify that, no. I think that would take pretty detailed data at the member level as far as monitoring what they utilized the year or 2 years after they first initially enrolled. But that was just not really in the purview of this assignment.
Thanks.
Mhm. Next slide. So another takeaway from the full cost analysis where we was that we pulled out the top 10 highest cost mandates. These made up 13.5% of the 17.3% of premium full cost of all of the mandates in total. We list out in the report some of the drivers we found behind why these might be in the top 10 higher cost. Some of the reasons are just that the mandate is very broad, such as mental health and substance abuse treatment covers a lot of different benefits and services. Some are just highly utilized, some of the wellness services and cancer screenings, and so on. So some of the cancer coverage, like the oral chemotherapy, are just very high cost, and so on. So you can read more about that in the report, but I just wanted to touch on some of those drivers. But we do note that the
Commissioner
marginal
Brzezinski had a
cost of these mandates is only 0.1%. Sorry, was there a question?
I have a question. For
Mhm.
the child wellness services, does that include the price of vaccines for children, or is that just the physician services?
Yes. It would include vaccines, yes.
I was surprised that was so high, that a wellness mandate is so high.
I mean, the vaccines are expensive, that might drive it, but. Or that the screening for cancer is more than, or similar to treating cancer.
Yeah, some of it is also because of utilization. You know, if you think of child wellness services, you have a large portion of kids utilizing those services. I will also say that there's a big gap. So 13%, 13.5% is there. A little less than half of that is mental health and substance abuse treatment. So there's quite a bit of a gap between that first most highest one and the subsequent 9. So even child wellness services was just above 1%. So even though it's in the top 10, it doesn't have maybe quite as much as it might seem of a full cost impact.
I'm surprised to see lymphedema treatment because there are not many patients for lymphedema.
I'm sorry, say,
I said I'm surprised to see lymphedema treatment on this list.
Yeah, but it's
Mhm.
expensive.
It's-
Lymphedema treatment's expensive.
Not as expensive as cancer treatment.
True. True.
Cancer
No,
treatments are much more than lymphedema treatment.
yeah, we noted from some research that we found that it particularly secondary lymphedema is the most common cause of disease, affects about 1 in 1,000. So part of that attribution is to utilization. It is also an average cost of around 15 grand. Again, the full cost is about 1% of premium. So just because it's in the top 10, not necessarily meaning that it's such a big portion as you might think.
I make a comment. I just feel kind of happy in a way that some of the things that are causing or that are part of the most expensive or the most cost, 10 most costly, saying it wrong. But anyway, all the prevention things to me could be bending the cost curve down the road. And so I think it's a wise investment is my only comment.
So
um,
as we,
I did have one question for you, because I was looking in the report where you did the breakdown and it said it was 13% for mental health and substance abuse. And I'm wondering if maybe that category is too big. Like, are there sub mandates within that? And not for this report, but in the future that we should be thinking about breaking that 13% down, or are they all of a piece? You see what I'm saying?
so I
Yeah.
just want to make sure we're clear. The mental health and substance abuse is about 6%. The total of the top 10 is about 13.5%.
I see. Okay, but it's still about half of all the mandates.
Yeah, it's still a large amount. And it's just a very broad mandate. So it seems hard to break out. You just kind of, I will admit that a lot of services, mental health and substance abuse services, are allocated to that cost because it is such a broad mandate. It's hard to parse out. But I understand your comment for the commission.
Thanks.
We did, as a note on that, we did also have, I don't want to misspeak here, but I pulled some research from the Commonwealth Fund saying that behavioral health spending accounted in their research for nearly 6% of all healthcare spending in 2016. And as we know, there's been a bump in behavioral health spending since then, post-pandemic. So all in all, it turned out to be not that surprising compared to some of the other research that there is such a big cost percentage allocated to this category.
Go ahead, Tracy.
Thank you. As we move into the marginal cost, just to mention that even though these top 10%, these top 10 full costs are 13.5%, they make up a marginal cost of only about 0.1%. And I'll explain a little bit about marginal costs as we get into the next slide. So to parse out, what we wanted to try to parse out from marginal cost is just the portion of the cost that is induced by the fact that the benefit or service is mandated. And there are several reasons why a portion of the cost wouldn't be induced by the mandate. Some of the ways you could understand that are to understand if the carrier typically covers this service outside of areas where it's mandated. So maybe prior to the mandate becoming effective, the carrier already covered it, or they covered it to a certain level and only had to increase a portion of it due to the mandate. Same goes for if it's covered in a market in which it's not mandated or another state in which it's not mandated. Another reason is if it's already required by the ACA's EHB requirement and associated benchmark plan. So in this way, even if the mandate was repealed, there may be a portion of the cost or a full amount of cost that would still be there even without the mandate. So we define the marginal cost as the full cost minus the benefit cost that would remain even if the mandate were to become ineffective or be repealed. This approach would produce the residual cost that's specifically induced by the mandate. Going to the next slide, as I mentioned a little bit earlier, a large majority of the mandates are covered by the EHB plan, and even further, some of those that aren't in the EHB plan may just be typically covered either fully or to a certain extent by the carrier, regardless of mandate. So the marginal cost that we're left with is approximately 0.8% of the premium when averaged across all markets. And I did check that is a weighted average by premium. Any question? Yeah, any questions?
I have
on
a
the
question
marginal
about
cost?
this analysis, and also what we're gonna do with it. In the individual and small group market, that 0.3 and 0.2% is really just reflects the fact that those are just mandates, not in the essential health benefits.
Correct. And yes, I meant to mention that ahead of opening up for questions. Yes, the EHB requirement does not, or the benchmark plan requirement does not extend to the large group. But what we heard a lot from carriers is that large group benefits, within reason, tend to mirror in the small group because of for employer competitive benefit reasons. So it is higher for the large group, but perhaps not,
I was surprised there wasn't more difference.
astronomically.
Then even in the individual and small group, how it worked is it doesn't really mean that those aren't mandates. The Care First, selecting the Care First small group plan as the benchmark, that plan was actually a rich version of the benefit package defined by the MHCC for the small group market before the ACC. Like the whole thing is a mandate, right? Like we mandated, the MHCC mandated benefit package. It got built into the Care First plan, which was one of the richer benefit plans built on that. Then it got built into the EHBs. So when we're talking about marginal increase here, it's sort of like, there's a lot in that box already. There wasn't much added to it.
Right.
So I was just wondering then, in that context, what is the significance then of the marginal cost? What do we do with that information? Does that question make sense? Why do we want to know it? How's that?
I mean, from my perspective, I think it just brings context to the fact that when we look at the 17%, that's the full cost, just knowing that most of that is not being induced by the specific health insurance mandates that are currently enacted. I realize that, to your point, in a roundabout way, they're still mandated through the benchmark plan, but just more to say that if you repealed all of these, a large part of the cost would still remain.
At least in the individual and small group, because they're stuck with the benchmark plan. I'm not stuck. I don't mean that pejoratively, because they have to have the benchmark plan.
Mhm.
What you're saying, okay. Thanks.
On the next slide, we went into an evaluation of the compliance of these mandates within the self-funded market. Most self-insured plans are regulated by ERISA and therefore are not required to comply with state mandates. A lot of self-insured plans are very customizable and flexible, so we didn't get a lot of detailed data on how each of those plans are built up. We more got general or more broad responses about what's typically covered, or an approximate percentage of how much it's covered. So we broke these down into compliance rate ranges shown in the table to try to give an evaluation of how often a specific mandated benefit is covered in the self-funded market. In summary, 60 out of 68 of the mandates had a self-funded compliance rate of half or more. Is there a question?
That question, for my own understanding of terminology, and when we're saying self-funded, that's a business that funds insurance for its own employees. This isn't an
That's correct.
individual self-funding. These are businesses, right?
That's
And
correct.
that's what you mentioned earlier, Chairman Sargent, that this self-funded data is outside of the medical claims.
Right.
database.
Because they're governed by federal law, and the Supreme Court decision said the state couldn't mandate that the federally governed self-funded plans submit data. That was the case.
Gotcha.
The thing to look at with self-funded is they are really a alternative to the large group market, because you have to be a certain size before you can self-fund, because you need to spread the costs out. So one way to think about mandates is individual and small group are what they are. That's all there is in those markets. But in the large group, you might be careful, because if employers don't like the mandate package, they can self-fund. They have other options. So.
Very good point.
And essential health benefits don't apply. There's more of a flow there. You can have minimum packages if you want, both in the insured market as well. So you should look at that market separately. It's competing with self-insurance.
Absolutely. Then if we go to the next slide, the last part of the analysis was to do a comparison of Maryland's mandates to its neighboring jurisdictions, specifically Delaware, DC, Pennsylvania, and Virginia. There are a few very detailed tables in the report regarding the mandate's relative value in each of the neighboring jurisdictions, as well as cost impact for Maryland to match that state's level of mandate, either removing or adding in either direction, and as well as an appendix that specifically points out in the codes where each of these comparable mandates are for the neighboring jurisdictions. But in summary, Maryland's mandates demonstrate a similar overall value to the neighboring states, whether looking at reducing mandates to align with surrounding states, adding to achieve parity with surrounding states, or doing some combination of both. We're looking at Maryland's full cost value remaining within 4% of any of those moves that could be on the table. Any questions about that?
Any commissioners with questions?
I will just go to the final slide and just wrap up and reiterate sort of the major conclusions that the full cost of the 68 health insurance mandates in Maryland's about 17%. Most of these mandates, however, are covered by the benchmark plan and or outside of the individual and small group market are just typically covered outside of the coverage induced by the mandate. So the marginal cost attributed is a little less than 1%. Most of the mandates are covered by most of those entities that choose to self-fund their health insurance. And in comparison to neighboring states, Maryland's mandates demonstrate a similar overall full cost value.
Question. So, you know, we often hear in this commission reviews of legislation that failed, mandate legislation. One that comes to mind was the cranial prosthesis. You know, there was a mandate bill that insurers should pay for cranial prosthesis. You know, it would cost, we'd see analysis, you know, 33 cents per member per month or something along those lines. So say that legislation eventually gets passed and it goes into law. And then the next time you all do this evaluation, because that mandate has been put into law and all insurance products should cover it, is that considered part of that base insurance plan that everything's compared against? Or would we see the cost of these mandates go up by 33 cents the next time you do analysis? So basically what I'm asking is, you know, this marginal cost of these mandates, it sounds like you're comparing it to a plan that incorporates all the mandates. You know, because every year we look at all these different bills and it seems like if all these mandates were implemented, it'd be several dollars per member per month. But you take most of the mandates and compare them to an insurance product that has the mandated coverage already. So I'm just wondering for the future, when we, you know, discuss these things, are we really seeing the effect of all the mandate bills that gets passed is only, you know, a few cents per member per month or a few dollars? Or is it really much larger, but because everybody already does it, we don't compare it against that?
I think there are several factors at play. It's possible that something you mandate is already covered by the benchmark plan, in which case the marginal cost would still remain low. If there is something being mandated that's not already covered by the benchmark plan, the marginal cost would go up. However, some things to consider about whether something is covered by the EHB plan. There's not a ton of flexibility in changing the EHB plan. I do think there have been, I know there have been some bulletins that Maryland's put out that have changed the benchmark plan and some of the benefits. But we also noted that some of the mandates that are more recent, I shouldn't say some, I should say all. I can't remember the exact date when this was enacted, but when the possibility of defrayal with state mandates came into consideration, a lot of the mandates you all in Maryland, you know, that Maryland put out were either stated that this wouldn't apply to the small group and individual markets because of the need for defrayal. With the exception, I believe, of one mandate that may need to be defrayed. But anyways, I think some of the mandates that are coming up are not applying to the individual and small group markets because of the defrayal concerns. So I don't know, that was just a few thoughts that come to mind of, you know, there's sort of like a few different factors coming into play here. But it's not to say that when Maryland mandates a benefit, that automatically becomes part of the benchmark plan, because Maryland would either have to put out a specific bulletin to make it part of the plan. And there's quite a big process to change the plan, of which I think there's a state law in Maryland that makes that even tougher. So it just kind of depends. But if it is already covered by the benchmark plan at the time it's mandated, it wouldn't increase the marginal cost for the individual and small group.
For the sake of our commission, my concern is some legislator will look at this and say, wow, I've been in a legislation for 8 years, and the last 4 years, all these mandate bills only cost 0.8% of premium increase. Let's approve everything everyone wants. You know, I'm afraid this is giving a false sense of low cost for all the
I had that
mandates.
concern. It's a legitimate calculation. I am a little concerned with how it might get used.
Yeah.
My understanding that they did update the benchmark plan in 2017. That's actually the second one. The first one would have been, I think, 2013 at the start of the ACA. That was also a Care First plan. So when and I think CMS instituted an update for everyone in 2017. That rolled all the mandates up till 2017. So if they do that again, that will sweep the mandates up. So if you came back in our 2021 benchmark plan, you're really going to have all the mandates up to that date swept into it. If it's still the 2017 plan, I guess the marginal cost will mean more. So we're adjusting.
Interesting.
Yeah, certainly. I don't doubt that using the marginal cost without having an understanding of the full cost is a particularly full picture. So definitely using those two in conjunction is important. I think part of the marginal cost, parsing out the marginal cost is helpful for things like the mandate for mental health and substance abuse treatment, where it is such a broad mandate that a lot of services get put under that umbrella. But, pretty much every health plan out there covers some level of mental health and substance abuse treatment. So you don't kind of want to maybe attribute all of that total cost to the mandate when it is part of the benefits that are typically being offered. So I think that's the intent behind parsing out the marginal cost, but I do understand that there's a nuance in there with the EHB plan and with the benchmark plan, and it being a plan that already incorporated a lot of the prior state mandates.
It's probably worth noting that the statute references the marginal cost. It's actually required analysis. Commissioner Jensen.
Yeah, I mean, it's a required analysis, but also I think looking at either one of these numbers in isolation is misleading.
Right.
So you would have to look at the marginal cost in the context of the total cost in the EHB. But the
Agreed.
reverse is also true. If you just said, hey, these mandates cost 17.3%, that's not actually accurate in a vacuum either.
Yes.
So they
Yes.
have to be presented together, I would think.
I totally agree. Yes.
Great. Any other questions or comments? That. Thank you very much.
All right.
Tracy.
Thank you. Thank you for your time.
With that, does anyone have a motion to approve the mandated health insurance services evaluation, comprehensive analysis of Maryland's mandated health insurance services?
So moved.
Commissioner Jensen has moved. I second. I saw Commissioner Gilroyd first. Second is Commissioner Gilroyd. And any additional discussion, questions, or comments? Okay, all in favor, say aye.
Aye.
Are there any opposed? Motion passes. Very good.
If I could. So just, this report is due every 4 years to the legislature, and it actually is a question that it gets asked of the commission staff periodically when a mandate is considered, like, well, how accurate are these estimates that you provide? This kind of gives a historical record of what mandates that have already been enacted cost. And you can, if you look at this through over time, you can also see new mandates, what we estimated and what they turned out to actually cost. We haven't actually done that exercise, but the House has asked for that comparison periodically, because when we have a new mandate, from the standpoint of the legislature, sometimes it seems kind of artificial how we've come up with it, because we are basing it on actuarial principles that they've been told by stakeholders or carriers it's going to cost nothing, or the carriers is going to be really expensive. And this provides some grounding. It's not perfect, and I think before the next one, we probably have to think about what we do with reinsurance in the individual market. It'd be very hard to fold back in the full cost of the premium if reinsurance wasn't there, but it does strike me as, at least a fairer way to look at the impact of mandates in the individual market. To consider what the cost of that insurance product is independent of payer. And of course, with reinsurance, federal government, and to a lesser extent, the state are actually kicking in money. Those premiums are important. Fortunately, we have 3 years to think about it. Truck's backing up right now, so.
So I think we have Ken. You have a chance to introduce a new staff member.
We are pleased to have Mr. Jason Kaplan. Mr. Jason Kaplan comes from the Maryland Department of Health, Office of Government Affairs, where he was the Assistant Director, conducting analysis and providing insights and recommendations on legislative proposals before and during the Maryland legislative session. Mr. Kaplan did play a big role, a critical role in this current session, and still are providing some activities there to help out the department. Mr. Kaplan has a law degree from the Widener University School of Law in Harrisburg, Pennsylvania. Mr. Kaplan's role in the Center for Analysis and Information System will be special projects, which was held by Janet Innes, who retired last August. We're very excited to have Mr. Kaplan join our team. Join me, welcome Jason.
Thank
you. Turning to agenda item number 4. Tracy DeShields, Director of Policy Development and External Affairs, will give us a legislative update and review the bills that are a priority. You have the floor, Tracy.
Thank you. Good afternoon, commissioners. So I'm just going to do just really a broad overview of legislation thus far that's going on, and I'll just bring you up to speed on where things are at this point during the legislative session. I have a lot of slides, but I'm not going to go through each of them. Just generally, next slide, please. So just a few quick stats. Where we are on Monday was crossover date. That means House bills have to go to the Senate, Senate bills go to the House. If the bills don't cross over by that time, by March 18th, I think it's 5 o'clock is sort of a time frame. Then it has to go to rules, and then you have to try to get it out of the Rules Committee. Some bills will come out of rules, will go to rules, will come out of rules, many will not. So, and right now, there have been no bills that we're tracking or following that has passed. They've crossed over, but so the balls are in the air, if you will, at this point. April 1st is the day 83. The budget bill needs to be passed. I only think one other time have they not, at least since my tenure, that they've not passed the budget third day. So, and then April 8th is adjournment, sine die. So that's a Monday, and everybody looks forward to that. They look forward to 12 midnight when they're done. Okay, now we're done. Next slide, please. Pass this on. Next slide, please. Sorry.
Sorry, Tracy.
It's okay. I'll wait for you. Next slide when you get there.
To be muted.
Great, thank you. Okay, so I'm just going to focus on their 4 main bills, and I'm going to focus on those and then a couple of studies as we go through. So this one is Senate Bill 1. It's actually 1059, House Bill 1051, maternal health assessments, referrals, and reporting. And this bill would require providers who accept Medicaid and provide obstetric services to complete a prenatal risk assessment form. This form would be done during the first visit and then again during the third trimester for the patient. And then the information is then the local health department is sent to the local health departments, and the local health department would then send it to the department. And the idea being is obviously what they're trying to figure out around maternal health is certainly risk factors, right? And trying to prevent any risk factors, or at least being very aware that there are risk factors for women in certain population groups and age groups. So, and then the department would then submit a report to the General Assembly each year with aggregate information from those risk assessment forms that they receive, the information. So this particular bill also would require the establishment of the department to establish a report card on birthing facilities. And they are to do this in collaboration with the Healthcare Commission. So, and the report card would include information related to the number of vaginal deliveries, C-sections, the rate of complications, both for vaginal birth as well as a cesarean section, and what that would mean. And then any qualitative measures based on patient input regarding the patient's receipt of respectful obstetric care. So, and then they have to balance it. They have to reevaluate the report card, adjust it, make various adjustments to it. And again, that information would then be posted to the department's website. So if you're a consumer, you could actually look at that and see that information. Next slide, please.
Would that go on our quality reporting website as well?
Yes, Tressa.
Yes, that's what we were proposing, and we supported the bill saying that we'd like to use that as a platform.
That's quality stuff.
Right, and I think, you know, I mean, we have the experience with creating the report card, so I would think that we definitely, it says collaboration, but probably would be a major role in that development. The next bill deals with nursing home acquisitions. So this was an important one because this one came out of our work group, nursing home acquisition work group. Did we? We skipped a slide. Can you go back one? Oh, great. Okay. So this one is on House Bill 784, Task Force on Reducing Emergency Department Wait Times. So I'm bringing this to your attention. This similar bill was passed last year that created a work group to look at ED wait times. MHCC was a member of that particular work group. I believe the final report has not been issued yet. So another bill was put in to create a task force to more formalize, and to look at the same issues to come to resolution. So right now, this bill has not moved out of the House. There is budget language that has been put into the budget language that's been introduced that would require, sorry, I'm gonna go back to my notes here, okay. Where a commission would be formed to look at ED wait times. And so, and then this would be with HSCRC and MIMS. So the Maryland Institute for Emergency Medical Services System, they would establish the commission or the work group, and they're required to have a third-party consultant who would then facilitate or be involved with the work group, and to really come up with robust recommendations. I think the legislature's very, very tired of this issue. It comes up every so often for a bazillion years. And they want it resolved. I mean, nobody can really pinpoint it. There's a whole lot of anecdotal stuff. Oh, that people get stuck because of behavioral health. Oh, whatever. It's always, but there are no numbers.
I have some commentary.
Okay.
Yes, there's a critical behavioral health problem in the state and the nation that does create impossible waiting times. Agreed. But ER wait times are generally a systemic problem in hospitals. And I just trying to picture how you legislate that away. I mean, it seems like I get it that we need to reduce the wait times, but it almost feels deaf to the real issues, which are systemic management of throughput in hospitals. And the last thing I'll just say is all the incentive to reduce wait times makes a lot of hospitals go on bypass, right? Because their wait times are too long. But if one hospital goes on bypass and everybody else around them doesn't go on bypass, they have to answer to their boards about why they have wait times, but they're getting inundated by patients who are not in other perhaps large or small facilities. So it's really complicated. I've spent a lot of time on this, published on this. And I love the idea that everybody wants to make it better. I worry about legislating it better without, to your point, really what do those onion peels look like that we could tackle? I'll stop.
The problem is, we have the longest wait time. Maryland has the longest wait times in the country. So I think this is something that if I were on the legislature, I'd want to be looking into it. I think it needs to be looked into. I agree, it's complex and some of it, you know, may or may not go to our the way we're financed.
You're here.
That's,
Certainly
it's money. That's what it is. If you want to pay for the capacity to have a throughput run quicker, if you want to pay for the capacity to have short wait times, that has to be built into the cost that's approved by the Cost Review Commission.
I would
That's
actually
just-
say that the finance side of it is there's a lack of competitive market forces to drive customer focused service.
That's just, I would argue, I would push back on it because this isn't a competitive market. This is a regulated market.
Right, because it's
So-
regulated, you
And
guaranteed
there's not enough
revenue
money to
regardless of the number
incentivize
of
the
visits that come.
hospitals.
Yeah. You can do that, right? And if you're in Baltimore City, you can go to GBMC and have a shorter wait time than if you go to Union Memorial, and everybody knows that.
The
But
hospitals-
if you're gonna try and legislate it, it has to come out of HSCRC, and it's gonna cost more money. Period.
And I want to be clear, I'm not saying we don't work on it or legislate it, but when I'm listening to, well, people say it's behavioral health, it's that, it's something else. The lack of understanding of what it is makes the legislation, unless it's pretty specific, a little unwieldy to me.
Well, I think that's why, you know, it's like, okay, we're gonna put it in the budget bill. It's gotta get looked at. We want doable recommendations.
And I want to make sure we don't solve it here. It's a task force.
She is very good and helping.
That's the things that- But the commission, I understand, will be able to
And
have
we would be a
representative.
part of any
task
work
force.
group or anything like that. So I'm just saying.
So commissioners that have a particular interest in this issue might raise their hand about the growth task.
So that's the reason for bringing it to your attention and just to saying that I think the fact that it was parsed out into budget language or is an important element that the legislature is kind of tired of it already and they want to address it. They wanted to address
If you could be tired of it, this is important.
it. Well, I think
They're probably tired of it because it's a problem that
It's
can't
a
be
problem
fixed
that
without
can't-
spending money.
Well,
and They don't want to spend it.
they're not convinced that it can't be fixed.
They should study it more.
I And I think it can be fixed, so they should be tired of it not fixed. I mean,
Yeah.
we all feel that way.
Absolutely.
I'll stop.
I think another thing is overutilization, the ER as a primary care physician. They don't have primary care physician, and just seeing a primary care physician, there is a long wait time. They end up in the ER. They use like urgent care. It's a multifactorial. It's not easy to fix.
You just missed the pass.
All right, next slide, please. Next slide. Next, oh, there we go. Thank you. So, there's a delay. I know, I forget. Senate Bill 1000, House Bill 1122 deals with, nursing home acquisitions. So, obviously this bill came out of the work that was done, through the nursing home acquisitions work group. And we worked with, the industry, some other, stakeholders to get to where we are right now. And so we think we have a good product. The bill has crossed over into the House. Not sure if the Senate bill will move, the likely just move the House bill. The amount of work that went into that is yeoman's, but essentially it would require, as we say, a person who is embarking on an acquisition of a nursing home to file an application with MHCC within 60 days of that. And then the executive director has to complete a review within 45 days. He can approve with conditions, deny the acquisition, or refer it to the full commission. And then the full commission, the time frame doesn't change, but if it gets referred to the full commission, it's a full 60 days. But it's still, the time continuum is still the same one, as it's just not as short. If it goes with the executive director, it's 45 days. And then, next slide, please.
Our very own Commissioner Boyle has done a lot of the work.
My question is, reading the tea leaves, what are the chances of this passing?
No, I think that this bill will pass. Yeah, we had one little scare and we got over that, I think. And so I think the fact is that this is an issue that's been worked on for over a year. And you had a lot of buy-in, pain, sweat, and tears, maybe on our part. But I think all in all, there's a lot of investment. I think people do think it is a good bill. And, hopefully it does what we hope it will do, and that is to keep out bad actors from coming into Maryland. But I think at the end of the day, it's a good bill, and I think pretty much it's. You're welcome.
It
So,
passed unanimously out of the House. That's a good thing.
Good to hear.
yeah, and so it's over in the Senate Finance, and it'll likely a sponsor-only bill hearing, since there was really no opposition to it. And I would think probably next week or so. Didn't come up this week, but it would have been too short, I think, to do, since most of the bills came over on Monday. And schedule that. So the bill further would require, in determining if an acquisition is in the public interest, the ED would consult with the Attorney General. Also, if the executive director denies a request for acquisition, a person that's a party could submit a request to the commission to review the executive director's decision. And then certainly if the commission reviews it and issues a final report, that can be appealed to circuit court. So, within 30 days of the decision. Next slide, please. And then lastly, certainly any final decision would be sent to the Secretary of Health, Secretary of Aging, the Executive Director of OHCQ and the Office of the Attorney General. And then if an acquisition is approved, the nursing home would then be required to report to the commission for 3 years thereafter, basically providing a status report or an update on how things are going since the acquisition of the nursing.
Excuse me, and after that, it's OHCQ that they interact with. After the 3 years of reporting to the commission.
Right.
Just on their own, aren't they?
OHCQ
Inspected
still
by-
has to go in, do its surveys as required, complaint investigations and things like that.
They-
So there's way, yes, and so I would think if there's an issue, something would be flagged. Next
they
slide,
have
please.
Good funding to do it appropriately.
I can't
You'd have to
comment on
trust
that,
the
but I
client.
think so, yes. And then, you know, we would have to adopt regulations, in order to, implement the bill, so. Next slide, please. Great. So, also, one of the things that we worked on during this interim is trauma funding. So we had the commission on, well, the commission to study trauma funding in Maryland. And out of that commission came a number of recommendations, one of which was to actually potentially increase the amount of money that goes into the Trauma Physician Services Fund, so which we manage. So there is a bill, Senate Bill 1092. That bill has been amended now. The name has somewhat changed to Emergency Services Funding. And essentially, so the bill would increase vehicle registration by $40 overall. $7.50 would come to the trauma fund. And then $9 would go to shock trauma. And then the leftover money would go to the Maryland Emergency Medical System Operations Fund. And then also the bill would give MHCC flexibility with regard to dispersing the funds. So would increase the amount that we could reimburse for on-call, physician on-call, and then also issue grants, and not just specific to equipment, but grants of some sort that we could get, because there's always a balance in the fund. Next slide, please. Now, that said, there was another bill, House Bill 1439. The provisions of that bill essentially, especially the provisions dealing with the Trauma Physicians Fund, has been amended into the budget bill. And essentially, it's similar, it provides us with flexibility. It gives us leverage to increase the percentage reimbursement for on-call fees, and then gives us the flexibility with regard to dispersing funds. So that's in the budget bill. So it's interesting, both could actually pass. I mean, the budget bill is going to pass. I don't think that that language is going to come out, and it's likely Senate Bill 1092, I think also will move forward as well. So, so next slide. So those are sort of the four major bills that that we had interim work related to, and so that's come forward and fruition with legislation. Marsha?
Appreciate the update.
Sure.
What happened to the legislation for trauma centers that had to do with a levy on guns? gun
Okay,
management?
so, well, okay, so the likelihood of, I'm not sure where that's gonna go. There was incredible floor debate in the Senate on that particular bill. The last that I saw, it had been special ordered. I think, I'm not sure if it was, they actually moved it or not, because you can special order and then special order based on
What does a special order mean?
means that they, they hold debate on it. There's a question that comes up and we need to look at it. We wanna, and so the rule would be you lay it over, but you can only lay it over for so long, but you can special order something so that somebody can research an issue or maybe pose an amendment.
Okay.
I don't know. I can tell you that the bill hearing for the Senate, for the House bill in Ways and Means was like none, I mean, in a long time, none other. We don't really monitor Ways and Means very often, but it was pretty contentious bill hearing for the sponsor of the bill, as well as those sort of testifying in support. And then a lot of questions for those in opposition, which obviously would be the gun lobby, right? And then also individuals. You know, there was a guy that testified on the Senate side and the House side. His kids do some sort of gun sport. I don't even know. But he talked about the problem with taxing ammunition, and police officers, I guess, have to buy their own bullets, which I find hard to believe when they're off duty. No. Well, anyway, so I don't know. I don't necessarily think it will pass, but I could be wrong. I just don't think it will, or it won't pass in the form in which it was introduced, right? I mean, because actually a couple of ideas from some of the gun lobby folks, they sort of sound reasonable, like why put an excise tax, either do a sales tax or an assessment on them as a, you know, something other than whatever reason, I guess, excise tax they don't really like. So, yeah, so that's where we are with that right now.
Is that a bill that we're tracking?
Yes, because it actually provided some of the funds actually went into the trauma fund. Yeah.
Thanks.
So with that, then we have a few things that if they do pass, MHCC would be required to do a study. One of which has to do with Senate Bill 791, House Bill 932. This, I think, will definitely pass. And the study essentially would require MHCC along with the Insurance Administration to conduct a study on the development of standards for implementation of payer programs to modify prior authorization requirements for prescription drugs, medical care, and other healthcare services. And then additionally, the Healthcare Commission and the Insurance Administration, again, we would be required to establish a work group. And the idea here would be to monitor, I guess, implementation or how prior authorization is actually working. And then provide recommendations to the legislature. So it would be, to do this, the report, I believe, would be required in either October or December, the first one anyway, 2025. So, next slide, please. And then in the budget, there's budget language, one of which would require MHCC to do a study on private payer coverage of ambulatory surgical facilities. So there was language that it's part of the study. We are to look at sort of how ambulatory surgical centers could be aligned with or included in the total cost of care model. That particular piece has been struck. So in doing the report, we would do an analysis of the cost differential between procedures performed in hospitals, procedures performed in ambulatory surgical centers. And then also we are required to do, as part of the study, look at the policies and procedures for including ambulatory surgical centers in private payer plans. And then certainly we would make findings and recommendations to be submitted to the General Assembly.
We happen to know we have most of those per capita of any in the country.
I don't know if we do or not.
We know that. We looked into it a couple months ago.
Can I just ask a question that's really basic? Are we looking at this because rate?
Now, we're
I
looking
thought-
at it because I think there's an issue with a particular carrier that, certain maybe surge centers cannot become part of their in-network. I think that's sort of the issue.
I thought it was-
That's what yeah.
I thought it was the other way around, that a payer will say we'd rather it be done in an ambulatory surgery center because it's less expensive. And Medicare covers more and more in ambulatory surgery centers.
Yeah,
so-
I think that's also part of the reason to look at the costs and savings. So overall in all, but if you look at private payer coverage of the ambulatory surgical facilities, I think generally it's like, sort of like an out-of-network, in-network sort of thing, I think.
Is the insurance administration involved? I mean, they define the network adequacy standards for carriers. It's like,
I'm not sure, if historically Medicaid has been good for ASCs.
okay.
Oh,
So, and then, did we take my glasses off? I can see. Okay, so, next slide, please. So there are two other, studies that, MHCC would be a part of. So one deals with, recruitment and retention of anesthesiologists in Maryland. So we've been asked, along with the health department, and HSCRC, and to work with the Maryland Society of Anesthesiologists to study barriers in the recruitment and retention of anesthesiologists. And again, make recommendations to eliminate and any identified barriers around people getting into the field or whatever. And then, reimbursement for maternal fetal medicine. The committee's requests, the department, in consultation with, MHCC and the HSCRC to study reimbursement rates under the Medicaid program for services provided by maternal fetal medicine specialists. And the idea is to assist MDH in completing the study. They request that MHCC and HSCRC provide all payer claim data to the health department that is necessary to complete the study.
Is maternal fetal medicine a different specialty, or is that sort of OB childbirth?
It's where you send high-risk OB patients.
Yeah.
Yeah,
So it's a term, it's an existing term of art, maternal fetal.
it's the existing term. It's, yeah.
I
When
think
they
the high
go,
risk,
they would
high risk
still
is
go
probably,
to- oh,
high risk is probably symptom a different category. I agree. I agree. This is a maternal fetal is very broad category. It could be just OB also. It depends where you practice. Stacy, I have a question. Why do they have only about anesthesiologist recruitment retention? I think that's most of the position.
What was the question, Dr. Bindar?
Why only?
Recruitment and retention of anesthesiologists
Right.
only. You know, it's related to all the
Shortage.
positions.
There's a shortage in every specialty.
Every special, exactly.
I was wondering.
They have a very good lobbying group, is all I can say.
Oh, okay.
And they are
But
paid
they're
very
not-
well.
They do at the head of the table all day long is write letters to their senators.
And they are paid very well. They work in ivory tower. They have no weekend call, no evening calls. They play golf on the weekend. I'm serious. I'm just telling you the facts. Probably you're the
I
biggest.
don't think anyone's disagreeing with that.
There's no anesthesiologist here.
I don't understand.
That's the problem, though. Anesthesiologists will be able to share.
Right.
Right. It's a
Yes,
trauma
that's what I
surgeon.
think, that's
Yeah.
the
You can pay them to work with the
Payment
trauma
issue.
surgeons.
That's right. Is that it?
Yep,
we
okay,
get
I
through?
think that's it.
No, that's not it. I can make it in if you want. Next slide, please. Great, okay, so, lastly, there is, a budget language that would require, the HSCRC, to, and I included this because this is of interest with us, and then they're to do it in consultation with, us, MHCC, to submit a report evaluating findings and recommendation from the Commission to Study Trauma Center funding in Maryland. So the recommendations, so there were a number of recommendations related to data. So essentially, the report would include information such as the difference in incremental trauma expenses and standby payments incorporated in regulated hospital rates versus actual incremental trauma costs and standby costs that are subject to HSCRC rate regulation. Also, plans to audit annual supplemental schedules of regulated trauma costs provided to HSCRC by trauma hospitals. Pending the results of the audit, efforts to ensure all regulated costs for the 4 primary specialties are accounted for in regulated hospital rates. Plans to consider covering additional incremental costs that are subject to HSCR rate regulation. The status of aligning data systems with MHCC and MIMS to enable more complete analysis of trauma care, and specific timelines for implementing regulations made by the Commission to Study Trauma Center funding in Maryland. So, and the report has to be submitted by October 1st of this year. So
This is we had a bill like this last year where I think it might have been $125,000 of our budget was withheld until we issued some regulations. There's a
And
second one.
$125,000 has been held in their budget.
So, yeah, this is the HSCRC this time, but
Yes.
it seems unusual because if the
Not at all.
legislature asks us for a report, we're doing a report. Like it's
Right.
not going to be something you need to hold a budget over. Is
Right.
there?
I don't know, probably they felt that they should probably have some sort of stick. So that the report actually gets done. And
Have
then
we
so-
ever not done a report that was requested?
I'm sure it does happen, yes.
Yeah, I mean, I think one of the issues with the trauma report and was that this fall, the governor strongly supported covering trauma costs. That was a shock trauma gala that the Healthcare Commission staff didn't attend. And after that speech, the funding of trauma centers became an urgency in the governor's office. We were, we for reasons that were beyond our control, the trauma commission didn't get its appointed members until almost the end of the summer. And it took us a long time. So we didn't get the report done on January 1 as promised, but we sent it out and the legislation is moving forward. But there was, the governor's staff wanted that report that, as soon as possible. And they were, to say the least, disappointed that it wasn't available on the date that the statute said, but to our, defend us, we did not make the appointments to the Commission on Trauma Funding. That was done by the Department of Health. So we had 3 months in the summer where we could have been working, but we didn't have any appointees. So we didn't have the first meeting till I believe it was like August 23rd or August 30th, somewhere. And then we had 5 meetings. One of the challenges was that this very issue of HSCRC cost, we originally thought that was definitive, but then the trauma centers disputed that. We did multiple cost surveys. So it was a lot more work than we had anticipated, trying to get decent numbers on cost, which was the essential question. You know, how much of the costs are covered by the rate system? I still don't know. And it's kind of to their defense, they don't really put in buckets of money when they define a global budget level. They don't say, you know, 10% goes here, 15% for maternal fetal medicine, et cetera, et cetera. We give you this money, the hospitals decide how to do it. But when there is a contradiction here, because the trauma system is itself defined by regulations, but state regulations that define what they must do. And you know, they are saying, you must do this. The CRC is, you know, saying, we'll give you a budget, figure out how to do it. And I think the trauma centers are, quite frankly, they're high prestige, but they're not really a profit center in the same way cardiac surgery is, for example. So they always argue that we're underfunded, and no one can say to what extent we're underfunded. That saga continues. Thus, budgets. I find it amusing that we're now supposed to do a study on the credibility of the recommendations of the trauma funding commission, but such is life.
So next slide, please. So this is just a list of the bills that are out there still in play that the commission weighed in on. Next slide, please. So I think it's like well over 20 bills or something like that. Next slide, please. So these are the last in the line of that. Next slide, please. There we are. So I don't know. Next month, we'll have a better idea of like what passed, what didn't, but a lot of times you sort of don't know until the bill gets signed.
Thank you.
Thank you.
Agenda item number 5. In Virginia, by the way, the governor can like plan things out of the bill. Very end of the process, so you would know.
Actually, our governor can do that now too, the budget. Do
Oh.
line item veto.
It's in all legislation in Virginia.
No.
The legislature has to come back and object, or else the law is just rewritten.
Oh. Ooh.
Maybe I shouldn't have suggested that.
Seems like a time murdering idea.
Yeah. The agenda item number 5 is a presentation on Maryland APCD data use case, physician practice research database. At the September 23rd, 2021 commission meeting, the commissioners approved an MCDP data request application submitted by the Agency for Healthcare Research and Quality, AHRQ, to determine the proportion of licensed physicians within the state of Maryland providing medical services to a patient population based on the presence of billed healthcare claims data, and to determine the practicing associations between physicians and their practices. Dr. Herbert Wong, Director of the Division of Statistical Research and Methods at the AHRQ, and Dr. Jennifer Smith, Principal Data Scientist in the Healthcare Evaluation Research Department at NORC at the University of Chicago, will present key findings of the 3PRD project. I want to note that Dr. Wong served as an HSCRC Commissioner from 2017. In the latter years of his term, he served as Vice Chair of the HSCRC. Dr. Herbert and Dr. Smith, please proceed.
Thank you very much for that introduction. Again, my name is Herb Wong. I'm the Director of the Division for Statistical Research and Methods here at the Agency for Healthcare Research and Quality, also known as AHRQ. For the next 15 minutes, Jen Smith with NORC and I would like to describe to you a new database that AHRQ has sponsored called the Physician and Physician Practice Research Database, which the Maryland APCD has contributed to. Now, because I am a big Star Wars fan, the naming of the database was intentional so that the acronym for the database is called 3PRD. By way of background, I am trained as an economist and have spent my career in conducting research and policy analysis and in the data development activities. Like many people here at ARC, the combination of conducting research and the involvement in data development activities give us a little bit of an advantage in terms of building a research database that is useful to the field. The 3PRD is actually part of a larger ARC initiative called the ARC Data Innovations. And ARC Data Innovation is an effort to identify existing data gaps to build a prototype database to begin to address those data gaps. And for today's presentation, I'd like to start off by providing you with some motivation for this particular data development effort. And then I'm going to turn the floor over to Jen, who will provide you with some overview of how the database was actually built. Next slide, please.
Anesthesiologist there.
So ARC is one of 12 operating divisions within the Department of Health and Human Services. And ARC's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work with partners to make sure that the evidence is understood and used. ARC achieves this mission largely through funding healthcare research. ARC funds research through grants, but we also conduct certain initiatives through different contracts. In addition, ARC has had a long history in the data development and dissemination space. The flagship data programs include the Medical Expenditure Panel Survey and the Healthcare Cost and Utilization Project, also known as HCUP. Next slide, please. So over the last several years, there has been a growing recognition that the national healthcare environment has been really changing. And new issues on healthcare delivery emerge. Policy analysts are recognizing that they really don't have the right database to properly address a lot of these issues. More data are needed to inform public and private policy, especially to address issues related to equity, health insurance coverage, healthcare markets, and competition. Now, 3PRD was particularly motivated by the COVID national emergency back in March of 2020. And as the COVID national emergency emerged, the U.S. Department of Health and Human Services was seeking information to help inform how the CARES Act Relief Fund would be distributed. And the department approached ARC with many requests for information. Now, while we had enough information to answer many of these questions using our existing data resources, for example, information on hospitals, there was really no comparable information for physician and physician practices. And in general, the COVID national emergency highlighted serious data gaps to kind of inform policy. The physician and physician practice database, or 3PRD, is one of ARC's effort to close that data gap. So with that, I'll now turn the session over to Jen to describe to you ARC's newest database and how the Maryland APCD contributed to this particular effort. Jen?
Thanks, Herb. Next slide, please. So the overall 3PRD consists of 13 states, of which Maryland is one of them. Each state, we went through a similar process. We started with the plan phase, and then we went to acquire the data. So we did come to all of you, or some of you, several years ago and request the MCDB data for this purpose, and we're granted access to it. So thank you very much. Then we process the data, and by processing the data, what we're doing here is we're trying to align all the different data sources that we collected so that they are standardized regardless of what data source we obtained the information from. Once everything was standardized, we built the 3PRD. Then we tested the fact that the 3PRD met certain criteria of our project to include data quality, benchmarking, and also looking at outliers and assessing whether the database would truly address the questions that it set out to address. And finally, we are currently in the share phase where we are sharing the database with people that might be interested in using it. Next slide, please. So during the planning stage, we identified 3 types of data sources. There are data sources that are common to all of the states we looked at. 3 for identifying physicians, and then 4 that would help us identify practices. There are data sources that were unique to states, such as a state APCD data or other claims sources, and also state medical board data. Then there were 9 other data sources that we considered. An example of this would be the Association of American Medical College and AHRQ's Compendium of U.S. Health Systems. Next slide. Overall, we obtained the state medical board data from 21 states. We conducted an outreach to 7 states for their APCD data, and we ended up being able to obtain data from 4 of those states. This map shows the states where there is mandatory and an existing APCD. The dark gray are voluntary efforts, and the light gray are in the implementation or thinking about it phase. Finally, we obtained publicly available data. This would include NPES, PACOS from CMS, and the AHRQ Compendium of U.S. Health Systems. Next slide. Once we obtain the data, we set about to link everything together. This is also listed in more detail in the methodology report that I believe you all were given a link to. We started with the state medical board data and linking that to NPES. This gave us two key pieces of information. The state medical license along with an MPI. Then we linked that to the PACOS data information, which gave us 3 sources that have different levels of provider information. The 3PRD is focusing on physicians, not all providers. So we use these 3 data sources as our primary starting point for identifying who is a physician and who may have been a different type of healthcare provider. By physician, we identified physician as someone who had an MD or a DO degree. Next slide, please. Once we built our core physician file, we assembled and tried to align as much of the information that we had across all of these files together. As you can see, some data, some variables were consistent across states, and other states had pieces of information that was unique to their state or maybe to a handful of states. So California, Florida, Texas, and Washington gave us military affiliation. Maryland was one of the states that gave us board certifications. We used as much information from these to harmonize the specialty information. Specialty information was a challenge for this project. As you may know, not everyone lists their specialty the same way across different data sources. So we ran across places where a physician may be listed as a general practitioner in one data source and a diabetes doctor in another. And we used as much of our information as we could to determine what kind of specialty the physician had. Next slide, please. Once we harmonized all the data, we set about to build the 3PRD. The final 3PRD has 13 states. 4 of the states include APCD data, that's Arkansas, Colorado, and Maryland, and Washington. Then we had states with APCD programs or were developing programs, but we were not able to access the data within the timeframe of this project. Finally, we identified 3 states to help build out our geographical representativeness. Arizona represents the Southwest. Missouri borders Arkansas. We wanted states that bordered where provider policy may differ enough that we could test different provider policies as far as being effective or not. And then Montana, which represents the frontier states. Next slide. So once we had that core physician file, we started adding characteristics from claims data. So all states included characteristics from CMS Medicare fee-for-service and Medicaid data, although the sources may vary. I do apologize, I had a typo on this slide. From Maryland, we actually use the TMSIS data, not the Maryland Medicaid data. We were not able, we asked, but we're not able to achieve getting the Maryland Medicaid data within the timeframe of this study. So we did try, and it just didn't work out time-wise. So we use the TMSIS data. And then for other states, only states with APCD data included Medicare Advantage data and commercial data. Next slide. Using all of this data, we developed from that list of physicians, we added on different kinds of characteristics for that physician. These included whether they were actively practicing, the types of insurance they billed, their patient panel, such as their age and race mix, claims per month, patients per month, percentage of claims by payer. We identified their top procedures performed and their top diagnoses observed. Next slide. For the practice variables, how we defined practice was not necessarily by the organizational NPI. For this database, we tried to triangulate where the physician was actually performing or providing the service. So we used the TIN, the organizational NPI, and the servicing zip code to try to identify locations of service, if you will. And that is how practice is defined within the 3PRD. The practice database identifies the number of 3PRD physicians associated with that practice, the number of other providers associated with the practice, demographics of the patient panel, claims and patient per month, the most common specialty, and the focus of the practice. Definitions of all of these can also be found in the methodology document. Next slide. Looking at Maryland specifically, when we did our testing of the Maryland 3PRD database, we tested the number of physicians that we identified against the Association of American Medical College Workforce Survey. The year of the survey we used and the year of the data did not align. So we did expect some differences between the two. Specifically, we expected to identify more physicians within the data because it was more recent than the number of people in the survey. Also, we identified everyone who has a license or had a license, and therefore we recognize that we might be identifying people that may be working more in an administrative or research capacity that may not be present within the workforce survey. And as you see, there is about an 18% difference between the two. We did an assessment of cell suppression. And next slide, please. And then we did an assessment of the outlier data. So in the state of Maryland's data, what we found for the 3PRD, what we found was the physician associated with the most claims per month had 128,588 claims as their maximum claim.
I'd hire him though.
Um,
4,000 claims a day.
Well, we do have an explanation for that.
A bill under the
Yes,
same name.
he has 20 PAs working under him.
Yeah, exactly. Yeah, so this person we did look up, they are a pathologist working for Kaiser. And they worked for the Rockville Regional Lab. So typically when we saw this, and we did see this across states, the types of physicians are radiologists, pathologists, or they might be the medical director of the state for their immunization program. So there are a lot of other providers are billing under this NPI. So it's really not reflective of what the one person is doing, but it's reflective of the impact maybe that they are making on overall.
And
Next
they don't have
slide,
to talk
please.
to their patients.
No, they don't have to talk to their patients.
Human interaction.
So like I just said, we did see this pattern across every state. So it's not unique to Maryland. And there is a reasonable explanation for why this happens, especially if you are well versed within the healthcare system in the US. Next slide. So there are key elements to the 3PRD. We made the physician and then the physician practice databases linkable. So you are able to see information of the physicians, specific information of the physicians within a practice, or you can see the information of the practice if you're looking at just one physician. We created a global 3PRD provider ID, which will allow the identification of providers across state lines. We do recognize that there are some providers that would be in more than one location, so we created that global ID. We also looked at whether or not we could address these key questions, and we were able to identify the answers to these questions using the database. For instance, the number of physicians that had a license at a given point in time, and of what percentage of those physicians were actively practicing. By actively practicing, that means that they were billing for a procedure within the same year of being licensed. And then the number of physicians with licenses that may have recently expired that could be recalled if necessary, such as during a PHE.
Is that the physician or the license that expired?
The license that expired, not the physician, sorry.
And why do you need a unique provider ID? I thought that the NPI was the unique provider ID, that every physician only has one NPI in the whole country.
That's a great question. In building this database, what we realized is that there are a lot of states and a lot of different data vendors that are, or data owners, I should say, that are becoming more and more protective of the information that gets released by or on the provider. So by deciding to incorporate a global 3PRD provider ID, it would allow for us as if AHRQ chooses to build this database out, it would allow for providers to be tracked, physicians to be tracked without actually using the NPI or using a state-specific ID. So it would maintain the usability of the database, even if there continues to be a movement to protect provider information.
Thank you.
Any other questions?
We do not.
Next slide, please. Finally, the databases are being made available by ARC on their website. We created 3 different types of files. There's a public use file, or the PUF. This is basically a directory of physicians, a directory of practices, and there are no variables that have been derived from an APCD data. We also developed a restricted use file, or what we're calling a RUF, and that requires a DUA agreement, and there are limited variables from APCD data that does vary state by state, as we have different restrictions based on the DUAs that we made with that state. And then we created a geographic PUF, which aggregates everything up to the zip code level.
I do hope you're planning to call that the Gov.
Well, that would be a great acronym. Herb, we might have to adopt that.
So could you tell us how many anesthesiologists are practicing in Maryland?
No, we really wouldn't know.
Not really, really.
Before we get ourselves into too much.
Like, is this database ready to go? Like, if we had a question, like how many doctors in a particular specialty practice in Maryland? Would this database tell us that now?
Yes, it would. The physician file has all the physicians in it within Maryland, and it has their specialty listed. We did both their primary specialty and secondary specialty. I need to refer back to the methodology memo. So like if someone has the specialty of general practitioner, but they also have the specialty of anesthesiologist or anything else, they both would be listed. We did have a rubric as to which goes where. Forgive me, I just can't remember off the top of my head at this point.
So does this have historical data as well to see trends? Such as like over the last 5 years, the number of dermatologists in the state. Can we see that?
I wish. We only did 1 year at this point in time.
But it will have chronological data as you go forward.
Going forward, right?
That would be a question for Herb to answer.
You're muted, Herb.
Nope. Well, we could get back to you on that.
You can send Ben an email.
Yeah, but it's a great question because a 1 year slice is only good for that moment.
There's a question over here.
So Jen, this is Zainal. The question
Oh,
is,
wonderful.
can you guys hear me?
Yes.
Yes.
I think Herb has, he's using the government computer, and our government resources are very reliable, as you can see. 20 accounts. So yes, we are planning to produce the next updated or upgraded version. So we are hoping to have this thing in 2026. But again, everything depends on the funding and things in that nature. But that's the current plan that we have.
So what, the data contributors, what special access do data contributors get to the files that the sheriff files, or is there any provision for that?
Well, I think it is as Jen mentioned, is like state specific. In some cases, some states have like multiple data collectors, so it really goes by that level. So it depends on the states and our agreements and their comfort zone, what kind of information we can have it, what information has to be restricted. The agreement is, the way we do it, we try to make a win-win-win situation, meaning that we produce, the public can benefit, our federal agencies can benefit, but at the same time, we try to provide a copy of what we have produced to our state partners so they can use for their own research or work or things in that nature. Like for the 3PRD, Arkansas is a good example. We have produced one for them. They requested back to a copy from us, which we gave them, and they have been utilizing this for other work that they're trying to get some additional funding or grants from HRSA. So for those type of purpose, like we try to make it upfront to the extent we can, but sometimes things are not, clear. We don't know it. But again, it depends on, it's state specific, unfortunately. Or fortunately, maybe I shouldn't say unfortunately, fortunately. Because some states are, like a little bit like easier to work with. Some have more restrictions. As Jan had a great experience in past few years. It is. And then for the state of Maryland, we have been fortunate. We have been extremely fortunate. It has been great working with you guys. So on behalf of ARC, on behalf of our team, I truly appreciate your help and support. And, and hopefully we're producing more in this field.
Thank you.
Ben, was that your question?
So, yeah, we should take this offline. As you heard,
Yeah.
there is a study on anesthesiology that this data set may be of some value to us. So but I think that the ability to look at trends are going to be important. So this may be one of several we need to examine should this pass.
The GUF also could be classed with social determinants of health data and census data. Good level to have insight on where the doctors and the needs are.
Should be, not where they are.
So I would say, reach out to Herb and Zainal, and they can probably coordinate that with you.
Thank you.
Commissioner Gilbert, did you have a question?
I do. It's really more a comment. First of all, I think this is fabulous work. And I feel like it's such dynamic data that it's almost going to be obsolete as soon as it's done, unless we can keep going with it. And every 2 years might be a little hard to really use these data the way they're probably meant to be. So however we could think of creating a process where there's continuous update, whether we think of an IT way to do that versus a people way to do that, would be really important for everyone involved.
Thank you. All right. Well, thank you very much. That was very interesting.
Thank you.
That we have agenda item number 6. Ben,
Yes,
review upcoming activities.
Tracy did just hand me the late breaking, which is the gun excise tax bill did pass out of the Senate. It's now sitting in Ways and Means. So I think it passed like it was actually given votes on the floor. I think it passed like 27 to 16, which is exactly the split between D's and R's in the Senate. I don't think any Republicans supported it, but it's now in the House, and we'll have to wait and see. But, so in terms of other issues for April, we will have some regulations after several months of no action. David Sharpshow will begin with presentations on our progress in implementing House Bill 812, the protected health information. And we also have some proposed regulations on COMAR 1025-18. Those are going to be the two major items right now. We'll also hear from Teresa's team on the Consumer Report website, particularly as it focuses on hospital services. And I know that the attorneys want to talk with the chair about several additional items that could possibly go on the consent agenda pertaining to percutaneous coronary intervention, certificates of ongoing performance. They are generally presented one after another at commission meetings. They are potentially something that could go on the consent agenda. If there's nothing remarkable about them, but I think they want, the attorneys want to be sure that they have consulted you before I say that. So one way or another, some PCI certificates of ongoing performance will be considered. I can't say whether they're on consent or on the regular agenda of the month, and then we'll know the final resolution and actually probably beginning work on the legislation that passed in this session. I did want to just also note that in an attempt to really give commissioners a perspective on what everyone is doing, Dr. Blake had suggested this past month that commissioners at our lunchtime meeting can have an opportunity to provide what they're doing and how that relates to the work of the commission. Dr. Blake has agreed to be the first presenter in May. I don't think she actually knows that she's the first presenter in May.
Should know, it was her idea.
But I've gotten a couple.
Common result from having ideas.
Brzezinski have also agreed to present a work on timing with that.
I'd encourage the other commissioners to think about it. You know, this is an opportunity for us to know what folks are doing outside of.
Yeah, this is not a policy or it's not something that I think is beneficial. Makes good use of that lunchtime.
I think it would, personally, I think it would be helpful. We have a lot of, well, in my time on the commission, more new members than we've had in any, single year. So it'd be a great way to get to know other folks, what they're.
Very good. So
Everybody loves a story, right? That's right.
speaking of a story, how many people saw Masters of the Sky? Anyway,
With that, is there any additional business or shall we entertain a motion to adjourn?
So moved.
Second that.
So moved. Thank you, everyone, for your time and attention today.
Commissioners and staff, if you have a few minutes, stop by the small conference room. We have some coffee, and some sweet.
I see you, this is gonna be early.
Did I tell you about my
Thank you.
familiar background? Well, they called it.
I'll get Rowdy over here on the side.
Get a little bit on it and a couple of pictures. It's funny that it's sweet because it's actually dangerous.
No, we can't. Because we good for going over
And if you
now.
can't find it, I can show you. I've got a clip of him actually.
Charge it, don't forget to charge it.
Yeah. We 359.
I'm not finished.
Yeah.
Yep.
Yeah, that's right. Let me, we should bring that for a vote.
Yeah.
We need something to go.
Yeah, because it's been loaded.
That'd be interesting to me. Did I tell you what happened? My own. Oh, no. He shot down, but he wasn't in a pump, he was in a fight. Okay, so he did, he shot down.
Oh, look at you. I did my little short version. You did the long version. Yeah, I like this. Oh.
He shot up. It's a big deal.
And it's like step by step.
I love it. This is my brain's going a mile a minute.
Look at you, thank you.
You're welcome.
They put him in charge.
Oh, appreciate it.
In charge of an airport. He got dropped out of the airport, so I mean, after multiple times, these guys came to the gates.
So, where's your,
He was hiding out on.
document that he gave you to,
He did an email
It was a strange.
that I tried to.
That's where PTSD just.
so it'd be.
Which to me is.
First